Welcome to this Step 2 clinical knowledge review on gynecologic oncology test-taking strategies. This video is brought to you by Roadmap to Residency. Today we are going to break down the most commonly tested question patterns you will encounter for cervical cancer screening, endometrial cancer, ovarian cancer, and vulvar and vaginal disorders. The goal here is not to reteach the entire topic from scratch. Instead, we are going to focus on how the boards test this material and show you strategies to pick the right answer quickly and confidently. Before watching, make sure you have reviewed the reproductive and oncology chapters in First Aid and your question bank. This video will help you apply that knowledge on exam day. Here is what we are going to cover today. First, we will learn how to recognize the high-yield question stems for cervical cancer screening, endometrial cancer, ovarian cancer, and vulvar disorders. Second, we will practice applying test-taking strategies specifically for postmenopausal bleeding questions, adnexal mass workups, and abnormal pap smear management. Third, we will master the next best step question format, which is the most common way these topics appear on the boards. Remember, you should review the reproductive and oncology chapters of First Aid and your question bank alongside this video. We are here to help you apply that knowledge strategically, not replace it. Our first strategy focuses on cervical cancer screening age cutoffs. This is one of the most commonly tested topics in gynecologic oncology on the boards. You need to know these age-based guidelines cold. From age 21 to 29, screening is done with cytology alone every 3 years. Starting at age 25, the preferred approach shifts to primary high-risk human papillomavirus testing every 5 years. Co-testing with both cytology and human papillomavirus every 5 years is also acceptable. Screening stops at 65 if prior results have been adequate. Now the keyboard question is what triggers a colposcopy. Remember, atypical squamous cells of undetermined significance with a positive human papillomavirus test requires colposcopy. Low-grade squamous intraepithelial lesion in a woman over 25 requires colposcopy. And high-grade squamous intraepithelial lesion always requires colposcopy no matter the age. These are the exact scenarios the boards love to test. Review the cervical screening algorithms in First Aid and your question bank to see these in table format. Strategy 2 helps you split endometrial cancer from ovarian cancer because the boards often present both as pelvic complaints in postmenopausal women, but the workup is very different. For endometrial cancer, the classic stem is a postmenopausal woman with vaginal bleeding. The first step is always transvaginal ultrasound to measure the endometrial stripe. If the stripe is greater than 4 millimeters, the next step is endometrial biopsy. Make sure you know the risk factors: obesity, unopposed estrogen, diabetes, tamoxifen, and nulliparity. For ovarian cancer, the presentation is different. Look for a postmenopausal woman with a complex adnexal mass, ascites, and an elevated cancer antigen, 125. Ovarian cancer presents late, and the boards focus on what to do next. The answer is almost always referral to gynecologic oncology for surgical staging. Review these distinguishing features in the gynecology and oncology sections of First Aid. Now let us talk about high-yield stem recognition. For endometrial cancer, the classic board stem describes a postmenopausal woman with vaginal bleeding. They will often include risk factors like obesity, diabetes, or tamoxifen use to point you toward the diagnosis. The first step is transvaginal ultrasound, then endometrial biopsy if the stripe is thickened. For ovarian cancer, the board stem describes a postmenopausal woman with bloating, early satiety, pelvic pain, and a complex adnexal mass. Cancer antigen 125 is elevated. The next step is referral to gynecologic oncology for surgical staging. For vulvar cancer, look for an elderly woman with a persistent vulvar lesion, itching, or ulceration that has not improved with topical treatment. The risk factors are lichen sclerosus and human papillomavirus infection. The next step is always vulvar biopsy. You will find more STEM examples like these in your question bank. Here is our first practice question. A 32-year-old woman has a routine cervical screening that shows high-grade squamous intraepithelial lesion on her pap smear. She has no prior abnormal screening and no symptoms. She is not pregnant. The question asks for the most appropriate next step in management. Take a moment to think about what you know about high-grade squamous intraepithelial lesion and how the screening algorithm works. The answer choices are A. Repeat Pap smear in 1 year. B. Human papillomavirus testing alone. C. Colposcopy with biopsy. D. Loop electrosurgical excision procedure. Think carefully about whether this is a diagnostic or treatment step before choosing your answer. Let us walk through this answer. Step 1. Spot the pattern. The Pap smear shows high-grade squamous intraepithelial lesion. This is a high-grade cytologic abnormality. Anytime you see high-grade squamous intraepithelial lesion on a Pap result, your next step is always the same, regardless of human papillomavirus status or the patient's age. Step 2. Apply the rule. The board rule is that high-grade squamous intraepithelial lesion always requires colposcopy with biopsy. This is a diagnostic step, not a treatment step. You must obtain tissue before moving to treatment. Step 3. Eliminate the wrong answers. Choice A, repeating the Pap in 1 year, is only appropriate for low-grade abnormalities in younger patients. Choice B, human papillomavirus testing alone, does not change the management for a high-grade lesion. Choice D, loop electrosurgical excision procedure, is a treatment, not the initial diagnostic step. The correct answer is C, colposcopy with biopsy. Review the cervical screening management algorithms in first aid and your question bank to see exactly when each option is appropriate. Here is our second practice question. A 63-year-old woman with obesity and type 2 diabetes presents with new vaginal bleeding. She has been postmenopausal for 12 years and takes no hormone replacement therapy. Transvaginal ultrasound shows an endometrial stripe of 8 mm. The question asks for the most appropriate next step. Notice how the stem is loaded with risk factors for endometrial cancer, postmenopausal status, obesity, and diabetes. The ultrasound already shows a thickened endometrial stripe at 8 mm, which is well above the 4 mm cutoff. Think about whether you need more diagnostic information or if you should jump to treatment. The choices are A. Reassurance and repeat ultrasound in 6 months. B. Endometrial biopsy. C. Hysterectomy. D. Cancer antigen 125 level. Let us walk through this answer. First, read the question carefully. The stem describes a classic setup for endometrial cancer. A postmenopausal woman with vaginal bleeding, obesity, type 2 diabetes, and a thickened endometrial stripe above 4 mm on transvaginal ultrasound. The ultrasound has already been done, so the next step is tissue sampling, not more imaging or watchful waiting. Now, why does endometrial biopsy win? Endometrial biopsy is the gold standard for diagnosing endometrial pathology in this setting. Let us eliminate the wrong answers. Choice A, reassurance and repeat ultrasound in 6 months, is wrong because you should never reassure postmenopausal bleeding without a tissue diagnosis. Choice C, hysterectomy, jumps straight to treatment without a diagnosis. Choice D, cancer antigen 125, is a tumor marker used for ovarian cancer monitoring, not for endometrial cancer workup. The correct answer is B, endometrial biopsy. These workup sequences are detailed in your first aid and question bank resources. Now let us review some ovarian cancer pearls that are essential for the boards. When approaching an adnexal mass, the first thing to consider is the patient's age. In premenopausal women, most adnexal masses are benign functional cysts. For a simple cyst under 6 centimeters, observation with repeat ultrasound in 6 to 8 weeks is appropriate. However, in postmenopausal women, any complex or persistent adnexal mass raises concern for malignancy and needs further evaluation. The red flags to watch for on the boards include solid components within the mass, septations, bilateral masses, ascites, and an elevated cancer antigen 125. When the boards present you with a postmenopausal woman with a suspicious ovarian mass, the answer is almost always referral to Gynecologic Oncology for surgical staging. Do not biopsy or drain a suspicious ovarian mass. These details are covered thoroughly in the gynecology chapter of First Aid and your question bank. Here is our third practice question. A 58-year-old postmenopausal woman presents with 3 months of abdominal bloating and early satiety. Pelvic ultrasound shows a 7 centimeter complex left adnexal mass with solid and cystic components. There is ascites. Cancer antigen 125 is markedly elevated. The question asks for the most appropriate next step. This stem is loaded with ovarian cancer red flags. Think about what you know about the workup of a suspicious adnexal mass in a postmenopausal woman. The choices are A. Observation with repeat ultrasound in 3 months, B. Fine needle aspiration of the mass, C. Referral to Gynecologic Oncology for surgical staging, D. Start chemotherapy. Let us walk through this answer. First, spot the red flags. This stem describes a postmenopausal woman with a complex adnexal mass that has solid and cystic components, ascites, and an elevated cancer antigen, 125. Every single one of these features points toward ovarian malignancy. When you see this combination on the boards, you should immediately think referral. Now, know the board rule. Suspicious ovarian masses in postmenopausal women require referral to Gynecologic Oncology for surgical staging. Let us eliminate the wrong answers. Choice A, observation with repeat ultrasound, is inappropriate when there are this many red flags. Choice B, fine needle aspiration of the mass, is contraindicated because it risks seeding the peritoneum with cancer cells. Never biopsy or aspirate a suspicious ovarian mass. Choice D, starting chemotherapy, cannot be done without tissue diagnosis and proper staging first. The correct answer is C, referral to Gynecologic Oncology for surgical staging. This is a high-yield board concept that you will find emphasized in your question bank. Here is our fourth practice question. A 71-year-old woman presents with a vulvar lesion that has been present for 8 months. She has chronic vulvar itching that is not improved with topical antifungal treatment. On exam, there is a raised, irregular, 2-centimeter ulcerated lesion on the left labium majus. She has a history of lichen sclerosus. The question asks for the most appropriate next step. This stem has several important features. The patient is elderly, the lesion is chronic and has not responded to conservative treatment, and she has lichen sclerosus, which is a known risk factor for vulvar squamous cell carcinoma. Think about whether you need to confirm the diagnosis or jump to treatment. The choices are A. Prescribe topical corticosteroids, B. Vulvar punch biopsy, C. Wide local excision, D. Topical fluorouracil. Let us walk through the vulvar lesion answer and then cover some key vulvar disorder board pearls. The correct answer is B. Vulvar punch biopsy. A persistent vulvar lesion in an elderly woman with lichen sclerosus that has not responded to treatment must be biopsied to rule out vulvar squamous cell carcinoma. Choice A, topical corticosteroids, is the correct treatment for lichen sclerosus itself, but it does not address a suspicious lesion that could be malignant. Choice C, wide local excision, is a treatment step that should come after a tissue diagnosis. Choice D, topical fluorouracil, is used for vulvar intraepithelial neoplasia, but you cannot apply it without first confirming the diagnosis. Now for the board pearls. Lichen sclerosus presents as thin, white, parchment-like skin with itching and is treated with topical corticosteroids. It is a known risk factor for vulvar squamous cell carcinoma. Any new or changing lesion on a background of lichen sclerosus always requires biopsy. Also know that vulvar intraepithelial neoplasia is associated with human papillomavirus and is treated with excision or ablation. Review these vulvar conditions in the gynecology section of First Aid and your question bank. That wraps up our review of Gynecologic Oncology test-taking strategies for Step 2. Let us quickly recap what we covered. First, know the cervical cancer screening age cutoffs and what triggers colposcopy. Second, recognize the endometrial cancer stem with postmenopausal bleeding and know the workup sequence of transvaginal ultrasound followed by endometrial biopsy. Third, for ovarian cancer, when you see a postmenopausal woman with a complex adnexal mass, ascites, and elevated cancer antigen 125, the answer is referral to Gynecologic Oncology. Fourth, for vulvar disorders, any persistent lesion in an elderly woman with lichen sclerosus requires biopsy. Review the gynecology and oncology chapters of First Aid, Pathoma, and your question bank. These resources cover the details we referenced throughout this video. Make sure to visit roadmaptoresidency.com for expert tutors and residency advisors who can help you prepare for the boards and match into your desired specialty. If you found this video helpful, please like and subscribe to our channel for more high-yield board review content. Good luck on your exam, and we will see you in the next video.